bring Tim Henry up from Christ Hospital, an old place of mine when I went to med school, and good to see you.
Yeah, I think this will be quite complimentary to what Dino just talked about. So first of all, pleasure to be here. It's been a great meeting, and so my goal is to talk about revascularization. The first thing, and I have no disclosures related to this talk, but first of all, we had talked yesterday about the randomized cardiogenic shock trials and how we've inadequately looked at it. And if you see all the orange, so these are all the randomized trials in cardiogenic shock, and all the orange is missing data. So you can see that very few trials, one of the only things that every trial looked at was 30-day mortality. So we can do better. So what about multivessel disease in STEMI? So first of all, overall it's about 40 to 65% of patients, and there's worse clinical outcomes. And the issue is, when do you intervene, and what's the data? And it's more complicated, just like Mike just alluded to. Do you just do infarct artery only? Do you do multivessel disease, or so-called preventive PCI, which is what the PRAMI investigators called it? Same procedure, with or without FFR, in hospital, with or without stress tests, out of hospital, with or without stress tests. I'm going to answer I think the FFR is probably not helpful. In fact, the FLOWER trial was actually more pointed us towards preventive PCI. So this is actually a couple slides. There's a whole host of data that says the more vessel disease you have, this is 3 versus 2 versus 1. This is non-infarct related disease. Every trial shows that it's worse outcome. And that's really consistent with what Venno says. So we know multivessel disease is worse. But before we start on culprit shock, I want to bring up this. So this, for doing multivessel PCI in STEMI without shock, was a class 3 indication just a few years ago for all of us to remember. And then there was a whole series of trials. This is the PRAMI trial that showed that preventive PCI fixing every lesion over 70%. Actually, it was over 50%. And in the Culprit MACE trial, and that was at the same setting. The Culprit trial, actually, this is MACE at 12 months, did multivessel PCI within the same hospital stay, and again showed significant improvement. So those two trials then laid the groundwork for the complete trial, which everyone should look at. It's one of the most important trials for interventional cardiologists, and a lot of good lessons. 2,000 patients in each, randomized to complete revascularization or culprit only. And they were patient. First of all, they put enough patients in the trial, and they were patient with a 3-year follow-up, looking at these endpoints. And these are the primary endpoint, which was CV death or new MI, significant improvement with complete revascularization, if you see the blue line. And those curves are continuing to spread, by the way. And if you add in the co-primary endpoint, which was ischemic-driven revascularization, it's even more powerful. So clearly now our guidelines say that you should do complete revascularization. But the question is when? And in complete trial, you could do it out to 6 weeks. So, and when they actually have looked at the data, there was no difference in doing it at the same procedure, the same hospitalization, or shortly thereafter. Although we do have some data that the longer you wait, there are some events. Okay? So then you come with a culprit shock trial, and this was a class 2 indication, do it, and it's changed to a class 3. So these two have completely shifted. And the answer is why. So one thing is, if you look at multivessel disease, it's even more common with shock. Now you're talking about 80% of the patients. And this is the observational data that had looked at ahead of time, and most patients had only gotten culprit-only PCI. And that laid the groundwork for the culprit shock trial. And you've seen the final slide for this every time, but let's look at exactly what was in the culprit shock trial. Sometimes we forget who the patients were enrolled. So first of all, over half had out-of-hospital cardiac arrest. Really important point. So 52 versus 55, and it was higher, slightly higher in the multivessel. 2, only 60% had STEMI, so many of these patients were non-STEMI, another really important point. Three-vessel disease was common in 63%, and 24% had CTOs. So that's an even more complicating issue, and they did have low EFs. So this was a sick, multi-vessel patient population. And then what did they do? You know, even though our European colleagues say they always use femoral, 80% were, always use radial, 80% were femoral, by the way. And drug-eluting stents were over 90%. But look at this. What was the revascularization strategy? 90% in the multivessel had multiple lesions, but if you look at immediate of non-culprit, 12% in the culprit only also had it. And another, if you look at it, where is it? 17% had staged PCI. So almost 30% of the so-called culprit only had multivessel PCI. So that's a fair amount of crossover. Mechanical sport was only about 30%, and the duration of ventilation, and you can see these were sick patients. But hypothermia was only used in about 30%. So I think those are really important points. This is the results which showed that culprit only had a significant improvement in the primary endpoint, which was mortality and renal replacement. And all-cause mortality, importantly, was higher in the multivessel. So that was the lessons, and this is what happened. It actually went from a 2A level of evidence C to 3B, which is don't do it, which I think is a little too strong because that's not what actually really happened in the trial. And then the next point is, in terms of this complete revascularization issue, people completely less over, although Holger talks about this for sure. The one-year analysis was very important. If you take out if you look at the landmark analysis, there was no more change in mortality, but what there was a significantly higher need for subsequent revascularization in the culprit only. So I think the take-home point is the patients who survived, 30% had revascularization actually in the hospital, and another 30% had it by 1 year. So the level of revascularization is really, to Mike's point earlier, is actually high in both. And this issue about cardiac arrest, I think, is a really important issue in terms of that. Because when you look at the differences in why people died in the culprit shock trial, look at this. And I'm not going to spend. Brain injury was twice as common in the multivessel. And is that because there's a mismatch in terms of that? And is that the reason for the difference in mortality? I'm not sure, but at least we do it. It's at least worthwhile pointing out this is actually data from the Khmer trial registry data that actually shows multivessel revascularization is better than culprit only in shock patients. So I don't think it's so clear as 3B, and I still think we need a lot of judgment. And the problem is when you see multivessel disease, there's a considerable amount of heterogeneity. So, oh Lord, here come stances beyond our control. I don't think that's true. But I love this Yogi Berra quote. You got to be very careful if you don't know where you're going because you might not get there. So I think we still have more to learn, and I do think complete revascularization is needed. It's the timing that's the issue.
Tim, that was great. And again, it shows that we're still in the dark. So what are you doing? What's your strategy?
Yeah, it's interesting. I have this slide. Actually, I did it from when I was part of Mike in Minneapolis Heart. I did an analysis like how often were people doing it. And in this thing, there was 10 interventionalists, and everyone had done at least 500 PCIs. 500 primary PCIs. And when you looked at it, the range of doing a multivessel at the time, what ranged from 10 to 25%. And the average was about 15%. Right. And there was no difference whether it was cardiogenic shock or whether it was and actually most of it was based on judgment. Right. So I still think, it's just like even with a non-shock, there's times I fix it and there's many times that I wait. It depends on how big is the infarct vessel, what time of night is it, what's the creatinine, how complicated was the primary PCI, how big a territory is the non-culprit. And I think the same thing happens with shock. I think if you have a shock patient, you fix the culprit, and then there's a subtotal proximal LED, and the patient still seems ischemic, I will tend to fix it. Because I don't think it's as cut and dried as everybody wants to make it. And that's why I think when you really look inside the trial, I think we have more to learn.
What about contrast load?
What's that?
Contrast load.
Yeah, so that's a huge issue because you saw renal replacement as issue, and I think that, for example, if you have a very difficult culprit and it takes you a long time to use culprit, you should be done.
Right.
If you ever have slow flow or anything like that, you should be done.
Exactly right.
So that's the only time you should even think about it is if it's absolutely simple with the culprit and you haven't used that.
Absolutely. Panel?
Well, Tim, that was a really nice review. You know, it seems like it would be easy to affirm, but maybe not with religious conviction. The guidelines suggesting culprit only and staged in hospital PCI as the standard of care. Does that sound reasonable?
Yeah, it does. But, I think here's what makes it even more complicated, right? There's finances and there's AUC, right? So, like, when you do it, and all those things enter in as well. And I do really think, we know, like, so for non-cardiogenic shock patients now with STEMI, half of those patients are low risk and can be discharged within 36 hours. So if you actually put them off and stage them, a lot of patients would rather not come back and do another procedure. So that also takes a place. So I still think the most important answer to this is judgment. But clearly, I think culprit shock should say, think twice before you attempt a non-culprit at the same time.
Exactly.
And probably just to say that you mentioned that the endpoint might be affected by the secondary revasc, right, or repeat revasc. But that was done mostly after the endpoint. So I'm not really sure whether that's true, because the endpoint was 30 days. It didn't change anything after that, and Revasc is done after 30 days, at least in Germany, due to funding reasons. Yeah. So that came after that. So I think it's still a good study, but I completely agree. I also tend to do, if it's really easy, and if you just spend 20 mil on the first lesion, why not go for the second one? And that the truth might be between
First of all, I think culprit shock is one of the most important trials that we've done, because you actually had a large number of people that were randomized. Yeah. But that doesn't mean you shouldn't still look inside the trial and figure out the patient.
Well, the grid you showed complete revascularization in the culprit only to be only 17%. And I've listened to the language of these talks for a really long time, and I for sure thought the number was much higher.
Right.
Right? I mean, that is a...
Yeah, see, that's the history. It's called culprit only, but 30% of those people had multivessel revascularization, even though it's not. So it's not exactly culprit only.
Well, I guess that in the trial, we do not have information on why these patients were crossed over. But if you have to think at what would be the clinical guidance for triggering this complete revascularization, I guess that the hemodynamic state or the severity of the hemodynamic state should play a role. I'm also guessing that even though echo was mentioned just before, it's very unpractical to do echo between one lesion. Okay, I do the echo. Yes, I go for the second lesion. No, this will not be done. So you can do this only afterwards. So what would be, in your mind, the triggers beyond the amount of contrast, of course, but to trigger to do multiple vessels instead of just culprit if the patient is whatever?
Yeah, so I can tell you, I had probably a month, maybe it's even 6 weeks ago, cardiogenic shock, really on the border cardiogenic shock. They'll fix the LED culprit for sure. And then the patient had inferior ST elevation and had a subtotal mid-RCA. Well, I know the culprit shock data, but you think I'm not going to fix the right? I fixed the right. And that was a patient kind of on the borderline, and, didn't even require mechanical circulatory support. But, you have to use your head.
Yes, but based on what? I mean, you base it here on EKG. That's one of the way. So what else? If you have to recommend something to our colleagues.
I'd actually say that the trial absolutely supports your conclusion, because I think, and this is sometimes a bit lost in the naming of the intervention arm, but the study protocol, in fact, encouraged the operators to do a staged PCI during the hospital stay, so it was not culprit only. And I think what is important to note in this context is that I would interpret the trial as it gives you the freedom not to do everything in the index event, and you can use your own judgment on the complexity of the lesion. And as you said, if it's very easy, you can do it, or you can defer it, but you still should do it in the hospital stay or shortly after. So I would say that the trial kind of completely supports what you said.
Let's leave it at that. And we want to thank Dr. Henry.